that back to Kumud, I would like to ask you this. In simple ways, could you make it easy for our audience to understand when would you make the decision to move someone from mechanical ventilation towards ECMO institution?
Dr. Atawar, if I may, even before Dr. Dhital asks that, if for the lay people out there, what is ECMO?
Oh, yeah. Okay.
Sure. Good. Okay. ECMO is what stands for ECMO, stands for extracorporeal membrane oxygenation. It can be in the form of either supporting both heart and lungs or just the lungs alone. And that depends on where these cannulae, these pipes are placed. So typically in the COVID scenario, it's a matter of assisting the lungs. And therefore you would have a pipe typically in the groin that is fairly large, and it draws blood out, puts it through an oxygenator and a pump that then puts the blood back in to another vein, usually in the neck. Now, for people of fairly smaller size or who don't need as much flow, there is a single cannula that can be used in the neck. It's a lot more expensive, but these are the two typical configurations. And we won't go into the other aspect, which is the veno-arterial or so-called VA ECMO, which is for heart support as well. Now, very few people with COVID have a cardiac problem that also needs supporting. And so we won't go into that. Majority are called VV, veno-venous ECMO support. Now, when do you need that? You really need that when you have exhausted your non-invasive first ways of supporting the patient on oxygen therapy to high flow to potentially then having to have ventilation. Now, one of the things that's really been missing is a proper dialogue between clinicians at our end of extreme care of the very, very sick and those that are having to deal with it on a daily basis. Now, I've been on an ECMO retrieval, and I can see that in the public hospital. I was amazed at the amount of work that they had to face from doctor-patient or nurse-patient ratios that we in the corporate setting have a greater luxury of. And therefore, I understood why it was almost impossible to have a dialogue, as Unmil suggested, between the treating clinicians and us to find out all that important history. And often you have to rely on the relatives who also are limited in the contact they can have with the physicians and, of course, their loved ones. So there is a difficulty of trying to get the very essential information first. But when you then need the ventilation and you're intubated, that's helpful in itself. That's the next level that most hospitals are able to cope with. But the problem is, if you want to give them the best chance, you really have to try and do various things with it. You have to try and alter the position of the patient. So turning them on their fronts, if you will, proning. We know that helps, but very few institutions have the capacity, manpower to do that on a regular and necessary basis. Now, the complication then happens is that on a ventilation, if you've been on a ventilator for more than about a week, typically the patients will get inserted. Well, you'll be having a tracheostomy or a little hole in your neck to ease ventilation. That allows you two important ways of managing the patient. One is that you can try and wake the patient up. And this is not happening in the majority of centers. Because if you wake the patient up on the tracheostomy, you can engage them, you can give them physiotherapy. They're only limited by the fact that they cannot speak to you. Now, given that anyone ventilated for COVID is unlikely to come out of a ventilation for a number of weeks and might need ECMO, it is imperative that we try and keep them awake as much as possible, because otherwise they will lose so much muscle. They will get ICU neuropathy, they will get myopathy, loss of muscle, loss of nerve function, and they will lose so much muscle that, in fact, you will end up, if it's a transplant candidate, with no muscle to then help you breathe. The lungs alone will not let you breathe. They're just bags. You need the strength of your chest wall and your diaphragm to be able to breathe properly. And that then the rehabilitation becomes so bad, as I said earlier on, that you will not get them out of hospital. So even right back, when the patient's being ventilated, you have to think about the end game of where you're going. And so you have to start proning. You have to assist these patients with physiotherapy, which has to be aggressive. And again, in many hospitals, they do not have the sufficient manpower of physiotherapy to do it 2-3 times a day. But now what happens is you've exhausted your ventilatory ability to support them anymore. Their oxygenation is very low, limited. The CT scan shows very destroyed lungs. and there's no improvement that's worrying. You're now worried about infection elsewhere outside of the lungs and having now multi-organ problems. So what do? You say, now, as long as Unmil said, there are criteria, well-written criteria and guidelines for who should be a recipient, a candidate or not, then you refer on to a transplant center. Now, the transplant center, if it has all that detail, can advise you about, listen, it's not worth it. Please talk to the family. This should be now palliated. Or, wow, we should give this patient a chance. 23-year-old that Sandeep mentioned, absolutely, single organ failure, who's exhausted ventilatory support. You would do whatever to try and make sure this chap got a chance for a lung transplantation. Absolutely. So you would transfer them to a center. And of course, you're stuck with where do you send them? Where do you send them? Now, if you look at the MOHAN Foundation website, they have a list of approved heart and lung transplant centers in India. And you'd be surprised. There are about 100 or plus or minus for both organs. And yet there are only probably 3, 4 that are actually doing any volume of work that should be done at this level. Because if you're not doing a decent volume, you should not be attempting it in the situation of a COVID patient, which is perhaps the most complicated thing you could be doing, not just the tricky surgery, which we can talk about, but in terms of the actual team that is used to looking after these patients cohesively, to look after them, particularly post-operatively, to make sure they're guarded against the infection, which is almost inevitable without somebody knowing very well the complexity of immunosuppression and interaction of drug-drug interactions, which when to try and mitigate against infection, that is a crucial knowledge that people like Unmil have, who are dedicated transplant pulmonologists. And if you don't have those dedicated transplant pulmonologists, it is exceedingly difficult to keep patients alive in the long term, let alone the short, complicated phase. So that is a normal progression of how you go it. But I would again go back. Don't assume you're transferring for a lung transplant. You're transferring for a higher level of care that may, all things being well, allow your loved one to have a lung transplant.